Honorable chairpersons, honorable moderators, I feel it's a great privilege for myself actually to become the faculty of the National Heart Foundation virtual conference in this year. I will say that it's a great pleasure actually to be also the co-speaker in front of Professor Mujibur Rahman, who is all one's favorite, and at the same time sharing co-speaking with Professor Diman Bonik, who is our very close by cardiologist. I would say that I would be delighted to say myself as the most daring person today because I like to talk on the part of the cardiovascular complication in front of the eminent cardiologist of our country, and I am not a cardiologist. So this is a privilege. I will say that as because Professor Mujib sir said that it's an evolving disease, so everybody doesn't know everything. And that is the reason why I take the chance to say something on the part of cardiovascular complication in front of our very, very eminent cardiologist of our country. So with this few introduction, I like to start my presentation on the part of COVID-19 pandemic and cardiovascular complication. Let me start with the case actually. 72 hours back, I had faced one of the doctor. I'm not going to mention her name. She's near mid-30. She was in the COVID-19 status in the August month and was admitted in a hospital of Bangladesh with a severe COVID pneumonia. And she recovered completely during the time of August. But during the time of recovery at home, she started feeling that palpitation is going on with her. And interesting phenomena that after her COVID, she developed severe hypertension. She now needed at least 2 drugs to control her hypertension. She was never been hypertensive before. She said that she started to develop the impaired glycemia when she started at home rest. And interestingly, her diabetes is now controlled with 60 units of insulin. The complaint was very simple. Occasionally, he got a fluctuation of her oxygen saturation at home. She said that occasional palpitation started, and when I move from one room to another or few stairs, I feel like fatigue and I feel like serious problem with my saturation. And sometimes saturation drops to 88 to 86. And she then consulted few of the specialists in our country. Unfortunately, many of the radiologists actually done the CT scan repeatedly with an X-ray. She done an ECG and echocardiography. All reveals are normal, and she was prescribed with some of the anxiolytics. Unfortunately, when I saw her pulse was 136. Her saturation was quite good. And I said that, can you please walk around in my chamber at least for 1 minute? And she done that, and I found that her pulse just rapidly goes to 152. So I prescribed him for the 2 investigations. One is the lung function test with DLCO, another is a cardiac MRI. Now look at this one. His restrictive lung disease has been identified with a poor DLCO. And the cardiac MRI has been done showing up that T2-weighted STIR evidence of the hyperintensity signal. And if you saw the LG chambers, you can identify there's evidence of LG in the PSIR. I must say that a cardiologist in front of us, that you all know the Lake Lewis major criteria of diagnosing myocarditis. And look at these pictures of her. This lady has developed myopericarditis just after the recovery started from the hospital. And unfortunately, she was not diagnosed. So with these few things of the new cases of the case vignette, I like to show you the importance of the cardiovascular system in the COVID-19, as because it has a direct impact on the part of case fatality rate. This is a publication from the BMJ, and which actually compared between the SARS, MERS, COVID-19, influenza, and different locations around the globe. And what the plot is on the left side about the risk factors, and see the odds ratio to find the case fatality rate. Now look at the cardiovascular disease. The odds ratio is the 13, where others are 7 and 9. And it was also to be shown in the SARS cases, the odds ratio was highest in the cardiovascular system. Now, when COVID-19 came up for the first few months, everybody was so much busy with ARDS. Everybody was concerning with the respiratory system. And then nobody cares about the botherations, about the mortality issue by means of cardiovascular system complication. And now that it becomes in the field, I say a pandemic is going on, but underneath this pandemic, a sub-pandemic of the cardiovascular system is putting on in our danger by means of COVID-19. Now, this is the hypothetical mechanism, what is going on. Actually, you all know that the SARS-CoV has a spike protein, and it can combine with the AC2 receptor, as said by the Professor Mujibur Rahman sir. But the issue is that beside the lungs, the endothelium of different locations, the body can be involved. The major endothelial cell which have the ACE2 receptors is the cardiovascular systems and is the heart. And not only this endothelial cell of the microvessel can be involved, the major vessels of the coronary artery means the macrovessel can also be involved by means of these combinations of the SARS-CoV-2 protein S and the ACE2 receptors. Now, beside this, there has been evidence within the 7 to 8 days time of the illness, it can directly involve the myocardium, as because myocardium cell has lots of ACE2 receptors. And when it does so, it causes the problem of increase the metabolic activity, and the inflammation at the endothelium goes on side by side, which causes the problem of the serious inflammation in the body, including the activation of the macrophage and T cell, leading to the cytokine storm. Now, another important issue is that as it involves commonly the lung causing the inflammations in the systemic way also involve the T cell and macrophage to have a lot of cytokine to be released. So you can easily see that when we are concentrating the puts on our heart, it not only causes the microvessel as the macrovessels, the hypoxia and the metabolic demand all leads to the serious amount of inflammation and cytokine availability for leading to the amount of hypothetical mechanism of cardiovascular involvement. Now, the big issue is that when the myocardial cell has a lots of ACE2 receptor, what will happen if the S protein garret comes back? They said that there's a two terminologies been established. One is called the fulminant myocarditis, another is called the simple myocarditis. The fulminant myocarditis happens when the virus gets a direct entry, causing the damage to the part of cytotoxicity within the myocardium. And it's a serious issue. It can lead to the death, even sudden death happen. Because whenever you are causing the myocardial damage, is causing the cardiac injury, not only the part, it causes the pre-existing plaque instability and rupture leading to acute coronary syndrome. And all phenomena, coronary syndrome, myocarditis, fulminant, other issue can lead to the heart failure, and also the myocardial dysfunction lead to the arrhythmia. So this key manifestation is very unique and has been proven in many literature. Now, this is the publication that has been also put in the BMJ about the new terminology of acute cardiac injury. And they said it has a multifactorial risk issue. Now, the question was arises, was there a cause-effect relationship is there? The answer is yes. You see, there are a lot of the findings of this one, the older age, CV risk factors, CV diseases, all has been shown have a direct interlink with the COVID-19 infection, with systemic inflammation, with hypoxia, with myocarditis, with procoagulant state by means of inflammation. And these all factors can cause us either direct cardiotoxicity, can cause us hypoxemia-mediated cardiac injury, can cause us supply-demand mismatch for our heart and the vascular system, can cause a serious amount of inflammation leading to the cytokine storm, which can also impact on the part of myocarditis, can also has an impact on the part of cardiomyopathy, and also the inflammation leading to the development of hypercoagulable state of the DIC, which leads to the development of coronary syndrome, myocarditis, heart failure, and arrhythmia, the impact of the clinical manifestation. Now, interestingly, the Italian papers of this one of the Fatinia shows very nicely that the SARS-CoV infection causing the ARDS and invasion in the microvessel, leading to the development of myocardial injury in all through mechanisms. One of the mechanisms is oxidative stress. The other mechanism is the signaling pathway, viral myocarditis pathway, the existing type 1 myocardial infarctions of the coronary arteries, the drugs that is saying by the Professor Mujibur sir very rightly about the antivirals, about the many of the drugs which has never been used, like the chloroquine, hydroxychloroquine, ivermectin, the pre-existing CVT, the stress, the tocotsubus, and the catecholamine. All these things are actually causing the trouble to the leading to the myocardial injury. Now, this is the paper that's been published from the Chinese group, actually, in one of the important current cardiology report. This shows that the day-wise, if you consider about the respiratory phases within the 0 to 7, I would say that the next 7 to 14 days is a big concern with the cardiac injury. And this stage is also having the problem of the cytokine, which can lead to the multi-organ failure. This is the area where the people can also have sepsis, although which has been scrutinizingly saying about the bacteria, but it is a COVID-19, a viral infection, where the sepsis and the septic shock was an important critical illness criteria published by the WHO. An interesting point that direct viral entry through the ACE2 receptor into the toxin cell has been proven. Hypoxia-induced myocyte has been seen to have been insult, and immune-mediated cytokine syndrome has also been responsible, shown in this paper. This is another paper which has been published by a Japanese group. I will say that look at this beautiful picture showing on the left side the cardiovascular disease and on the right side about the COVID-19. And it says that not only the ARDS or the systemic inflammation or the drug is responsible, but a direct entry to the myocardium, direct injury to the acute cardiac injury, or by means of coronary syndrome or arrhythmia by means of combinations of factors and the thromboembolism can lead to the development of this serious cardiovascular impact. There are two groups of the drugs that has been concerned with the cardiovascular system. One of the groups of the drug that is used for the COVID-19, like the hydroxychloroquine, azithromycin, lopinavir, ritonavir, remdesivir, and favipiravir. On the other hand, there are many other cardiovascular drugs like the ASE inhibitors, ARB, as well as the other antihypertensive drugs, and sometimes the anticoagulant used for the pre-existing cardiac diseases. They can have a serious drug interaction when we are considering about the cardiovascular complication of these diseases. There was a white paper published by the JAMA about the current perspective of the coronavirus. What I'd like to mention that one of the important biomarkers shown by Professor Mujibur Rahman was the troponin. And they said that when the troponin elevation happens in COVID-19 patient, few things that can be associated with this one. One is the type 1 MI, we all know that, the pre-existing atherosclerosis. The type 2 MI, we all also know that, the supply-demand issues there. Other cardiac events like the pulmonary embolism, Takotsubo arrhythmia, heart failure, and also the establishing of the underlying cardiac condition, all can lead to the development of the troponin elevation. Viral myocarditis, either direct or immune-mediated, can have a troponin elevations in the COVID-19 and sources of a cytokine storm. But point is that whatever the disease it causes, these all are the strong prognostic value leading to the severe disease, leading to the ICU admission, leading to the ventilation, and also the mortality. On the right side, you can see there's a balance of emerging evidence of the cardiac insult by means of cytokine, IL-1, 2, 6, 8, and a lot of issues. They all have a directly relationship with the hospitalized case of the myocarditis in their studies has been proven. About the cardiac biomarkers and cytokine, is there any correlation? I would say yes, there it is. You will see that when we are seeing some COVID-19 patient about the severity of the disease, we feel few of the things like the CRP, the low lymphocyte, the LDH value, ferritin value, D-dimer, the IL-6. But the issue is that when the patient is dying, they shows this all the cytokines have a similar value in the form of raised troponin I, in the form of myocyte insult, and also the hemodynamic insult in the form of pro-BNP or anti-pro-BNP raiser. So you can see there's a direct relationship between the cardiac biomarker and the cytokine in the severe COVID-19. I will say some of the presentation of the JAMA about the cardiovascular magnetic resonance imaging patient who recently recovered from the coronavirus of the COVID-19. The picture is similar that I have shown you in my case vignette of the Bangladesh cardiac MRI, right? It's just similar. And on the left side, you can see the viral inclusion was identified by means of the immunostaining. Now, on that study, they shown that the healthy controls, the risk factor associated match control, the patient of the COVID-19 who was hospitalized on the right side and who was actually managed in the home, but recovered, look at the number they've shown their troponin T values. It raised up very high on the right two sides rather than the left two sides. And also when the time concern was being shown, the high sensitive troponin T was consistently seen to be raised
in the day 25, day 50, even up to day 70. So what we can see that taken together, we demonstrate the cardiac involvement of this patient was found to have 78% ongoing myocardial inflammation is going on. 60% of the COVID-19 illness who recovered from that illness has shown the problems remains in the cardiovascular system. And remember, these were independent on the pre-existing cardiovascular condition. These are independent on the part of severity. These were independent overall course of the acute illness. These were independent of the time from the original diagnosis. So can you imagine a patient having a mild illness, recovered completely, have a rest and home, get a snacks, go to the gym, and then he develop a serious myocarditis? That can happen, and it's happening in the COVID-19. Now, this is another paper which also showed from the JAMA said that how about a healthy heart people like the competitive athlete who recovered from the COVID-19 infection? And the MRI revealed the same picture in the T2, the myocarditic features, and the pericardial effusion of the pericarditis that have been seen on the right lower margin. So can you imagine these healthy heart people are suffering from the serious amount of myopericarditis after getting recovery from them, even mild illness. There was a many autopsy report has been published for the cardiovascular insult of the COVID-19. One of the autopsy cases I would like to mention that the pictorial, the copy number of the viral load has been shown on the right side, and the negative case shown on the left side. And they compare it with all the cytokine like the TNF, like the IL-6 and IL-8. You can easily see where the copy number of the virus was very high. The number of this cytokine was also very high. So also the concentration. But when we are dealing with the lymphocyte for protection, the negative cases have a more amount of CD protection by lymphocyte rather than the lymphocyte in the severe case of the cardiac issue. That's what's saying by the Professor Mujibur Rahman sir. The lymphocyte count becomes reduced, and the effective lymphocyte protection has lessons in the cardiac injury of these cases of the COVID-19. Now, these two pictures about the turkey glass appearance also shows the impact that the RNA has been shown within the myocyte of this cell in the autopsy report, which proven that it directly causes the toxicity. Is there any long-term sequelae? I would say yes, because Drinking et al. Was hypothesis that not only the acute insult will cause cardiovascular complication, but it can also cause long-term sequelae in the form of ACS, in the form of arrhythmia, in the form of shock, like the myocarditis of the immune-mediated and the venous thromboembolism. There has been one specific syndrome known as multi-inflammatory syndrome in the children. Now it is recognized and established. Initially, it was reported from the United Kingdom. Later on from the US, from 26 states, they say these are the severe cases in the children. About the ICU admission of 80% of those cases, about the case report that has been presented from the United States. And many of them needed mechanical ventilations. Few of the death also happens by means of dufotatal and tubianatal. And you can check the eyes of the children and the skin rest to make sure that you are dealing a long-term sequelae of the MISC2 in these kind of cases. So we can see that for the acute, we have acute onset heart failure, arrhythmia, acute cardiac injury, including the myocardial infarction. Myocarditis and cardiac arrest can be done by this of pro-inflammatory status. And the cardiac biomarkers and acute cardiac injury has been shown to bear prediction in the in-hospital mortality, where the p-value has been found very significant. And not only all the among comers have a cardiac injury, but also has been found to be significantly higher those who are non-survivor. So the routine phenomena is that you not only do the cardiac biomarkers in the initial measurement of hospitalization, rather a longitudinal monitoring is very crucial because that can give us an idea who's gonna have a good prognosis, who's gonna have a worse prognosis. I'm not gonna detail say something about the management because you all are experts on this part. What I want to mention is that the STEMI-related infection of the infection in the COVID-19 infection will remain same as the guideline based by means of American Cardiac Association or Bangladesh Cardiac Association or by means of European Society of Cardiology. Only one thing issue is that when we are dealing with the NSTI, if it is a very high risk group, then we can consider the management will be like that of STMI. Otherwise, we can have the time to test for the SARS-CoV-2 in these groups, and we can also proceed to go for the non-invasive as well as invasive testing in these groups of the patient rather than make in hurry. Another important pointer what I like to mention that there's a time from needle to door. We all know that for the STEMI. But for this patient of COVID-19 who can have a delay to go arrival in the hospital, we can have a 60-minute time of extra delay can be allowed. Arrhythmia is a big issue. Wang et al. Has been shown that huge number of cases having arrhythmia. And another study actually shows that it is even more seen in the critical cases rather than mild moderate case. And if somebody has a pre-existing cardiovascular disease, we must do such telemetric monitoring. And the COVID-19 associated with the tachyarrhythmia can be atrial in the form of flutter and fibrillation, and also the VT and VF in the ICU setting. Point of what I want to mention that the atrial fibrillation having their standard guideline mediated management is there. But what we need to see that our threshold value for choosing the anticoagulation and the rhythm control need to be very low in this respect of COVID-19 because it itself is a prothrombotic status and inflammatory condition. That is the reason why the threshold should be low. And second issue, if somebody has a COVID-19 infection and recover, we must reassess the rhythm for AF and anti-flutter. And also we need to reevaluate the rate and rhythm control and the anticoagulant strategy because we may need to reduce the dosage of the drug as because of the drug interaction can develop. About the BTBF, I'm not an expert as you can see, but we use many of the drugs like IV amiodarone, like IV beta blocker in the form of azmolol or procainate and lidocaine in these gauges. Now remember, these are the groups of the people who also receive the antiviral drugs, also the many other agents that you mentioned by Professor Mujibur Rahman. So be careful about the drug interaction when we are dealing at the BTBF. I will not say something about the Brugada and CPVT because patient with Brugada syndrome has been identified the COVID-19. What we need to see that if somebody has a Brugada has an ICD place or not. If he is in place, tell him to go home and remain in the isolation protocol will be best for him, unless there is no syncope or shock. But if there is no ICD present, if he's in the high risk group and febrile, he must be hospitalized. And for the CPVT group, is the catecholamine induced. So if somebody has a COVID associated CPVT patient, we must see that few things should be avoided. Even in the patient have got low pressure, we cannot give adrenaline, we cannot give isoproterenol, dobutamine in this group of patient or alpha beta blocker. The best drug will be a beta blocker or procainate, I would say, and also the public health protocol must be maintained. Acute is a big issue, has been very highlighted by our Honorable Professor Mujibur Rahman sir. But what I like to mention that everyone need to do an adult patient in ECG. If it is less than 500, then you can say that yes, we can proceed on. But if somebody has a prolonged QT, check all the modifiable QT prolongation is corrected or not, like stopping the chloroquine, like stopping the azithromycin. These are very crucial. And unless you do not correct it, please, we should not start the COVID-19 medication because it could lead to the catastrophic QT prolongation and the ventricular fibrillation followed. I told you something about the myocarditis. There has been many reports in the China and others where the methylprednisolone and immunoglobulin was being given for 4 days for recovery. There has been few reports about giving the plasmapheresis and the cytosorb, which is extracorporeal cytokine absorption in the cytokine storm that develop in the myocardial injury. I say that point of care echo can have shown that not only LV dilatation, but global hypokinesia, but new concentration said that there is multi-segment hypocontractility or reversal echo finding of the Takatsubu's cardiomyopathy seen in patients with multiple fulminant myocarditis, which could lead to the development of heart failure and cardiogenic shock, and the standard management should be actually followed by all these things. I would say that I will not go for the management issues of there, but the important point in this that guideline-directed medical therapy is still recommended for patients of chronic ischemic heart disease failure, irrespective of the COVID-19. There will also be guideline-mediated management for the acute heart failure in patients with COVID-19. Data on the acute heart failure COVID-19 is still scarce, but the management from all the authorities remain the same. Hypertension, and there the concern of the ARB and ACI has been cleared by our Honorable Professor Mujibur. I will not say anything, but what I like to mention that the comorbidities, among the comorbidities, one of the important was found to be at hypertension. And there's no evidence to suggest that hypertension per se is an independent risk factor of severe complication. It has not been proven. But newer conception in the COVID-19 say that whether a person will develop autonomic dysfunction and new onset hypertension of COVID-19 or not is to be seen in future. About the management issue, I say that this patient can remain as a self-isolated at home if they can monitor the blood pressure. There's no need for adjustment of any ACE, ARB has been shown. But for the hospitalized patient who have severe illness, who have acute kidney injury, you may reduce the dosage of the hypertension, and sometimes you may skip the antihypertensive medication because these are the groups of the patient can have hypertension as well as septicemia. Pulmonary embolism has been shown one of the important causes of mortality in COVID-19, and these are to be concerned in those patients who have a worsening respiratory worse or the tachycardia or chest pain or new onset in hospital. So these are the groups who are actually hypovolemia and sepsis and may have a DVT. If started to develop new onset dyspnea, think about acute PE. And the treatment should be guideline mediated. NOAC can be given, but be careful. If somebody is using the antiviral drug in the form of lopinavir, ritonavir, you cannot provide the NOAC. The best drug will be the heparin in any form, unfractionated or by molecular. That's because there's no major interaction happen. So regarding the treatment, what I would like to say that for STEMI and STMI, there will be a big consideration whether we'll go for primary PCR thrombolytics or not. For the myocardial injury, it remains a worse prognosis. Monitoring is a big issue. For hypercoagulable state, all hospitalized patients need thromboprophylaxis as a recommendation. ACA-ARB, currently, please continue the treatment. There's no problem with that. There are 4 randomized control trials coming on, whether it is beneficial or detrimental or not. Hydroxychloroquine, chloroquine, and azithromycin issue. If anybody has a QT prolongation, we should completely avoid this one. And these are not having shown to be any benefit as well. Immunosuppressive immunomodulators, that can be helpful sometimes, but very selectively to be given. And for the patient who have mechanical circulatory support, IABP and the ECMO is a 2 modality that can be ECMO can be given in these groups. This is a very big picture. I would not say anything about this. I would just like to show some of the color. The red color means these are the drugs that is used in the COVID-19 antiviral. On the left side, these are the drugs that are usually seen by the cardiovascular disease. Antihypertensive, lipid-lowering drugs, antiplatelets. These are the big interactions of the red area. We should not do it. The green areas are the area where we can proceed with the antivirals or other drugs with these groups of the anti-cardiovascular disease. Big issue of the anticoagulation, you all know that. And there has been also the red colors where you cannot use the combinations of these drugs with the existing drugs. Like you can see the azithromycin, you cannot provide with warfarin because it can cause the interaction. The green areas are the area where we can proceed. And on the left side, you can also see the lot of antiviral drugs and the intervention like the tocilizumab, fingolimod, interferon, porphyridone, all has been shown to have directly relationship with the NOAC or other drugs that is commonly used in the cardiovascular system. So this chart can be very good, helpful for any physician to select the issues of the drug. So we came to the last one, say some of the key messages about the cardiovascular complication in COVID-19. Patient with CV risk factor and established CVD will have a vulnerable population when they suffer from COVID-19. Patient with a cardiac injury in the context of COVID-19 have an increased risk of morbidity and mortality. Severe COVID-19 infection is associated with myocardial damage and arrhythmia. Monitoring of the cardiotoxicity of antiviral drug is recommended. Non-COVID-19 patient with acute CVD should be preferably admitted in the COVID-19 free area. Care of COVID-19 patient with severe CVD might be down-regulated for low intensity level. ACE2 receptors and the lung injury, cytokine release all lead to the development of this pathophysiology. Chest pain and breathlessness is the frequent symptom. Chronic and acute coronary syndrome can be a presentation. Impaired end-organ perfusion like AMI as well as the cardiogenic shock can be a complication. Myocarditis should be always considered by means of direct toxicity or immune-mediated. Symptoms of Brady and tachyarrhythmia do not differ from the usual clinical manifestation from the non-COVID illness. Proper pathway and guideline-directed mechanism must be maintained. The cardiac biomarker will be a very important issue of troponin T and the proBNP as well as the TMR. I would say focus, and critical care echocardiography is very crucial in patients having a cardiovascular complication with COVID-19. The key message is that, gentlemen, the Peter Levy says heart inflammation can be life-threatening, and it can be happening in people who do not have any pre-existing risk factor in COVID-19. So be cautious, be safe. Virus is everywhere. Thank you very much for being here.
Thank you, Professor Ravid Amin, for your nice deliberation and elaborate lectures and covering all the aspects of cardiovascular disease involved from COVID-19. So as we are running a shorter time, I have just one question has been asked from the audience. Any young patient, no risk factor, what could be the possible risk factor for death, Professor Ravid Amin?
You see, I told you during the time of hypothetical mechanisms of this illness, the endothelium has a high propensity of ACE2 receptors. So what happens that when the S protein combined with that, it causes serious inflammation, leading to the oxidant damage. Subendothelial valvular factor become polymerized, leading to the hypercoagulable state. So any young patient who does not have any pre-existing risk factor, even with the COVID-19, can have a inflammation and hypercoagulable state that leads to the microvascular as well as macrovascular thrombosis, leading to the major cardiovascular event. So that is the reason why Peter Levy says that somebody doesn't have any pre-existing cardiovascular disease, younger, but can death happen in such a catastrophe of cardiovascular mortality.
Okay, another question from how could we select the dose, especially for the rivaroxaban in your guideline, that is 10 milligram? Is it adequate for all body mass index population? Also,
you see, there is few things about rivaroxaban to say. People are using rivaroxaban at home, and they are using at the initial anticoagulation, which is not recommended actually. As I told you, the NOAC can have a serious amount of interaction with antiviral and many other agents that is used for the COVID-19. So primarily we must be sure that we started with the anticoagulation with IV, either heparin or bioimmune, so unfractionated or low molecular. But during the time of recovery, there was the few retrospective data showing that the outcome remains same with many of the NOACs. You can choose rivaroxaban and others. About the dosage, there has been no established recommendation from any society, but what they said that if somebody is using multi-drugs, think about the interaction that can happen in the rivaroxaban and other drugs, and in that case, you need to reduce the dosage. And the duration is also speculative, and the consensus idea is to give it at least a duration of 31 to 39 days. These are the studies. People are giving it for the 1 month duration of time at least, and this is also the lower level of evidence 5, I would say, rather than a randomized control trial. We will wait for the RCT to come up with all the answers for dosage and the duration.
Okay. Any question from Kalam Rabbani, sir?
Yes. Thank you very much, Professor Ravid Amin, for your excellent presentation. Just I want to know, the patient with whom we started describing, reported to you with palpitation and shortness of breath. May I know what was the ejection fraction of this patient?
Oh, yes, sir. About the index case, she came up after actually many consultation with expertise, I would say. The problem is that the radiation given by the CT and X-ray is actually very high, and it will not give us a remarkable benefit by a respiratory physician to see a CT scan after 4 weeks, right? You can check the CT scan or X-ray even after 3 months or 6 months to show the improvement. But the important is to the functional capacity of the respiratory system, which was not seen here. So that's the reason why I have given the lung function test. The echocardiography, which was done to this patient, shows the ejection fraction was around 62%. The ECG was saying that her pulse was sinus tachycardia with 102. And there was no regional hypokinesia was actually seen when the echocardiography was done in the last of the October. So that I decided on the part that the patient is symptomatic and she had a fluctuation, and she's a physician. So we should not just consider about the anxiety related to such amount of state. That is the reason why I selectively give her the cardiac MRI and the
But as a cardiologist, we say echocardiographic diagnosis of cardiomyopathy is that it should be dilated and there will be global hypertension and ejection should be very low.
Yes.
So how can we say that patient had your cardiomyopathy? Probably we can tell it as a myocarditis, not cardiomyopathy, but cardiomyopathy. It is echocardiographic diagnosis mainly. That should be dilated more than 60 millimeter. There should be global hypokinesia and ejection should be less than 30%.
Yes, sir, absolutely agree. And that is the reason why I told you the diagnosis was perimyocarditis of these cases.
Thank you very much for your excellent presentation.
Thank you, sir, for your Professor Amin. Thank you once again for your nice